This is Michael Altos recording Basic Principles of Clinical Pharmacology based on Barish Chapter 7. This is Part 2. We've talked about absorption and distribution of drugs, and it's time to talk about transfer and transport. We know the drug is on its way to the brain, and what actually has to happen? Well, there's a blood-brain barrier, which is made up of a lipid bilayer, and most of our cell membranes are made up of this lipid bilayer. So lipophilic drugs are usually able to cross this bilayer pretty easily through some sort of passive transport. Hydrophilic drugs have a harder time crossing this and may need to go through some sort of a channel via facilitated diffusion or even active transport, especially if they're moving against a concentration gradient. Before we go any further, we need to take a minute and do a quick review of acid-base chemistry. Drugs are typically either an acid or a base. For our purposes, we'll define an acid as any drug that can be dissociated into a proton and a negatively charged species. A base is any drug that can accept a proton to become a positively charged species. Well, we know that charged species don't cross membranes very well. And then we come to the pKa. And very simply, the pKa is the pH where ionization occurs. It's the 50-50 point. It's the point where half of the drug is ionized and half of it is not. Now, when the pH of the environment is more acidic than the pKa, I like to think that there's an excess of hydrogen ions and it pushes the equation to the right. When the current pH is more basic than the pKa, then I think of it as having a lack of hydrogen ions and the equation is pushed to the left. Let's see some examples of this. If we take a drug like etomidate, now etomidate is a base, which means that it can accept a proton to become positively charged. Etomidate has a pKa of 4.2. Now if I inject it into the blood, which has a pKa of 7.4, we can say that the blood, the environment, is less acidic than the pKa of etomidate. And I think of that as being a lack of hydrogen ions, which will push this equation to the left. And so the equation being shifted to the left makes this non-ionized species the predominant species. And that's great because that's the species that will cross the blood-brain barrier and put our patients to sleep quickly. On the other hand, we have propofol, which is an acid. Propofol dissociates into a proton and a negatively charged species. The pKa of propofol is 11. So even though it's in the same blood, now the blood is relatively acidic compared to the pKa of propofol. And I think of that as being an excess of protons, which pushes this equation to the right. And so the predominant species is this HA, which is again non-ionized. And propofol is non-ionized in the blood, which again allows it to have a very quick onset of action in the central nervous system. Let's take a look at this simulation over here. Here we're seeing a membrane dividing. On one hand we have our ionized drugs, and the other hand our non-ionized drugs. The charged drugs can't cross the membrane, but if we add some acid to one side of this, so here comes some protons, and the excess protons mix with the negatively charged drug to make a neutral species that can cross the membrane. Let's stop here for a moment. If you have any questions, you can make a note of them and bring those questions to class, or contact me and I can explain them to you in more detail. Now finally, the drug has had its effect, and it's time for biotransformation, or metabolism. Metabolism is really the process of making our drugs hydrophilic so they can be excreted, and this usually happens in the liver. There are phase 1 reactions, which are some sort of hydroxylation. This is usually done via the cytochrome P450 family of enzymes. Most commonly the 3A3, 3A4, 3A5 subfamilies. That's what we see for midazolam. In general, drugs can be biotransformed in many different ways by the cytochrome family. They can be oxidized or reduced, hydrolyzed, and a lot of drug interactions happen here if two drugs are competing for the same enzyme or changing the levels or activity of an enzyme. We also have phase 2 reactions, which is conjugation. For midazolam, this would be glucuronidation of the phase 1 metabolite, but we can conjugate it with other polar substances besides glucuronate, like acetate or glutathione. Again, the purpose is to make our drug more hydrophilic so it can be excreted in the kidneys. Just a reminder that neonates have a significantly diminished phase 1 and phase 2 activity. Now, when we're talking about hepatic metabolism, we're talking about a process that occurs, as we said, in the liver. And so there are some pharmacologic concepts that we need to review. We need to talk about hepatic drug clearance. And clearance, remember, is defined as the volume of blood the liver can cleanse of drug per unit time. And we understand hepatic drug clearance in terms of a few other variables, specifically hepatic blood flow, because obviously the more rapidly you send blood to the liver, the more it can clear. And the extraction ratio, how good is the liver at getting drug out of the blood and metabolizing it? So hepatic blood flow obviously depends on cardiac output. And the hepatic extraction ratio is defined as the fraction of drug that the liver removes from the blood as it passes through the liver. And these two variables together make up hepatic drug clearance. So some drugs have a high extraction ratio. That is, the drug is extracted very well by the liver, and so the liver is only limited by how much blood you send to it. We call this flow limited. And drugs like etomidate and propofol are good examples of flow limited drugs with high extraction ratios. And so the clearance of these drugs is simply proportional to blood flow. Send more blood, the liver will clear more drug. And this will be true unless the metabolic capacity of the liver is severely diminished. Let's take a moment and look at these two graphs on the right side over here. So this first graph is showing hepatic clearance in liters per minute as a function of liver blood flow. And so here's a drug which is very well extracted from the blood by the liver. And so we expect that as we send more blood to the liver will extract more drug from the blood as it passes through the liver. No surprise there. But as we have drugs that are less and less well extracted from the liver, that is, drugs with a lower extraction ratio, now here's a drug like thiopental or diazepam, where hepatic extraction isn't really very efficient. It has a low extraction ratio. And so as I increase hepatic blood flow, the liver sort of hits a ceiling and it can't really do much more, even as I increase hepatic blood flow. Now all of this is very nice when we're dealing with a healthy liver that has normal metabolic activity. And so we're seeing again the same distribution of properties here as we look at drugs with decreasing extraction ratios. And how does that affect clearance? This is for a normal liver. But now suppose instead of varying liver blood flow, we vary the enzymatic ability of the liver. And so here's a diseased liver. So which drugs are going to be affected by a diseased liver? So let's look over here. Here is a low extraction ratio drug, something like thiopental or diazepam. We said the clearance wasn't really affected very much by hepatic blood flow because the liver can only handle a small fraction of the drug that it sees because the extraction ratio is so low. So what really changes the parameters over here? The answer is hepatic enzymatic activity, hepatic metabolic activity. And so we can see here that as the liver becomes less metabolically active, we have decreased clearance. On the other hand, if you had enzyme induction, you would have increased clearance. Now, this would not be the case for propofol or etomidate. These drugs that respond very well to changes in cardiac output, which is hepatic blood flow, actually show very little change as in response to changes in hepatic enzymatic activity. And that makes sense because the liver is already doing such a good job of extracting the drug from the blood that you really have to get down to a very, very low level of enzyme activity before hepatic clearance falls off. These are graphs that we'll talk about more in class, but they're definitely something for you to think about. And what you really need to know is not to memorize this table, but just to be aware that we do have drugs that fall into different categories of low, intermediate, or high hepatic extraction ratios. So we can see some of our drugs like propofol, metoprolol, morphine, lidocaine, ketamine, fentanyl. Most of our drugs here really have high hepatic extraction ratios. So we're not really worried about the patient who has hepatic disease. We are primarily concerned about patients who are in a low flow state, who have low cardiac output. Those are the patients in whom metabolism may be changed. However, we do have drugs like methadone or phenytoin, some of the other benzodiazepines, and even rocuronium, where changes in hepatic blood flow may not have a big effect on hepatic metabolism, but patients who have induced liver enzymes or inhibited liver enzymes may actually show a change in their metabolism of these drugs. Now, all of this hepatic information stands in contrast to elimination, which, as we know, usually happens in the kidneys. Now, in the kidneys, we know that there's autoregulation, which maintains this constant renal blood flow over a wide range of cardiac output, and that's different than the liver. The liver's hepatic blood flow is directly proportional to cardiac output, but that's not the case in the kidneys. Now, this is complicated by the fact that renal clearance is really only a small fraction of renal blood flow. Due to protein binding, the protein-bound drugs aren't filtered into the liver, into the kidney rather. So really, even though we have a large renal blood flow, renal clearance is really very small. So how does the body make up for the fact that only a small portion of drug that goes to the kidney is actually filtered into the kidney? The answer is that there are active transporters in the kidney, and these renal tubular active transporters allow renal clearance to basically approach renal blood flow by actively transporting drug across the renal tubule membranes. So now when we talk about patients with decreased renal function, we have to change drug dosing because otherwise we can have accumulation of parent compounds or metabolites, and we worry about that especially in the case of active metabolites. And again, this is not a table for you to memorize per se, but we should all be aware that we have drugs out there and which drugs do have significant renal excretion. And some of them we're familiar with. We know that our penicillins and cephalosporins have renal dosing. We know that rocuronium to some degree has renal dosing. And we should be aware of these drugs as we treat patients who have renal dysfunction. That's the end of this video recording. We'll pick up again with the next installment. And as always, please make sure that you make a note of any questions you have so we can discuss them in the classroom. And you're always welcome to contact me ahead of time if you want to discuss or clarify anything.